Welcome back to Ultrasound teaching videos with Dr. Arshad Nadeem Awan. Hope you are all okay. Hope you are all enjoying and you are practicing ultrasounds as well. Today my topic of discussion is pancreatic cystic lesions. Pseudopancreatic cyst is one of the commonest cystic lesion of the pancreas, accounts for almost 75% of the cystic lesions. But you have to take the history. You have to take the history whether patient has any previous history of acute pancreatitis or chronic pancreatitis to eliminate the reason of the pseudopancreatic cyst. If there is history of acute pancreatitis or chronic pancreatitis, so definitely that cystic lesion would likely be pseudopancreatic cyst. If pseudopancreatic cyst is not there or history is not favoring pseudopancreatic cyst, so there may be two possibilities. The one is called as simple pancreatic cyst and another is called as pancreatic cystic lesions. Unilocular pancreatic cyst up to 3 centimeter or less than 3 centimeter is considered to be benign. If it is a multiseptated cyst, there is likely chances of malignancy up to 20% cases. Surgeons believe if there is a patient with high risk of pancreatic cancer, like if there is history of pancreatic cancer in his family, or the cyst shows some septations or internal echoes or debris, so it should be aggressively managed. Cystic pancreatic lesions become suspicious when patient is symptomatic and gives symptoms related to pancreatic malignant possibilities. If there is growth on the serial examinations, serial scans, you see that the cyst is growing and getting bigger. If the diameter of the cyst is more than 3 centimeter, if there is any internal soft tissue components within the cyst, or there is intramural soft tissue components, or if there is any septal thickening, then that cyst would be considered at high risk for malignancy and will need further assessment. Simple pancreatic cyst. Simple pancreatic cysts are very rare in general population and you will never see simple cyst while you are scanning. But if you see multiple cystic lesion within the pancreas, it will raise the suspicion of certain inherited disease. There are 3 inherited disease in which you will see multiple cystic lesions within the pancreas. The one is adult polycystic kidney disease. Adult polycystic kidney disease is the disease where both kidneys will be, the parenchyma of the both kidneys will be interrupted by multiple, rather numerous cystic lesions. So if the patients do have polycystic kidneys, so you may be able to see certain pancreatic cyst in that cases. The second case is von Hippel-Lindau disease. Von Hippel-Lindau disease is inherited disease in which multiple tumors and multiple cysts. Sometimes these tumors and cysts are benign, or sometimes this may be malignant, can occur in different organs of the body. That is called as von Hippel-Lindau disease. In von Hippel-Lindau disease, you will see multiple simple cysts within the pancreas. And the third is multiple fibrosis. So these 3 are the inherited disease in which the simple cyst can be seen in the pancreas. It is transverse color Doppler imaging shows 2 centimeter cyst which is discovered incidentally on abdominal sonogram and was followed for 4 years, but there was no significant changes in the size. It is generally safe to follow small completely cystic pancreatic lesion. On this image you can see aorta, you can see IVC, left renal vein, superior mesenteric artery, superior mesenteric vein is visible. C is denoting cyst. This cyst is 2 centimeter in large and was discovered 4 years back, but there is no changes in the size, so it was simple cyst, simple pancreatic benign cyst. On this transverse image, multiple simple pancreatic cysts are visible, white arrows indicating cyst. Splenic vein is visible, Cysts are involving head, body and tail region respectively. Cysts are looking simple without any intramural nodules or without any internal echoes. You can appreciate that there is no distortions of the wall of the cyst. This is case of von Hippel-Lindau disease. Von Hippel-Lindau disease is inherited disorder and causes multiple cysts and tumors in different organs of the body. In this case, you can see multiple pancreatic cysts. This is CT scan image of von Hippel-Lindau disease patient. You can clearly appreciate multiple cysts within the pancreatic head, body and tail region. If you carefully look into the slide, you will appreciate white arrow indicating hyperdense tumor in the left renal cortex with central cystic appearance. This is renal cell carcinoma. As I mentioned earlier, this is von Hippel-Lindau disease which causes tumors and cysts, and tumors may be malignant. So it's renal cell carcinoma with multiple pancreatic benign cysts. On this ultrasound image, you can see multiple solid tumors within the renal parenchyma. These are renal cell carcinoma. The kidney is visible, upper part cortical portion of the kidney is visualized, while 3 tumors can be seen here. It is annotated as RCC. On the lower pole, you can see a cyst. This cyst is simple. This cyst is round in shape and it is located in the head of pancreas, and this looks benign. No intramural contents are seen. No wall irregularities noted. Again, this is von Hippel-Lindau disease with renal cell carcinoma and pancreatic simple cyst. So we have discussed about the pseudopancreatic cyst. Pseudopancreatic cyst must be having relation with the history of acute pancreatitis or chronic pancreatitis. If the patients give you the history of acute or chronic pancreatitis and you can come across a cystic lesion, this would likely be pseudopancreatic cyst. If not, so then another chance is simple pancreatic cyst, which we have discussed. Simple pancreatic cyst can be seen in von Hippel-Lindau disease, or it can be seen in adult polycystic kidney disease, or it can be seen in multiple fibrosis. But major 90% chances are with von Hippel-Lindau disease. Apart from all these two, there are certain cystic neoplasms. Cystic neoplasms are categorized in 3 forms. The first one is called as serous cystic neoplasm. Serous cystic neoplasm are, in majority, these are benign cysts, but only rare chances of malignancy can be reported. But majority cases, in majority of the serous cystic neoplasm, you will see these cysts would be benign. The second is called as mucinous cystic neoplasm. Mucinous cystic neoplasm, and the third one is called as intraductal papillary mucinous neoplasm. These two categories are actually mucin secreting neoplasm, and these are often malignant. So we have seen 3 types of cystic neoplasm. The one is called as serous cystic neoplasm, the second is called as mucinous cystic neoplasm, and the third is called as intraductal papillary mucinous neoplasms. Cysts are usually small in size, ranging from 1 to 2 centimeter, but it may get enlarged up to 3 centimeters as well. Because of their confluent structure, it gives rise to presentation of solid mass. So in following slide, I will show how it will appear on the ultrasound imaging. Especially this cystic lesion involves the head region, so therefore you have to be very careful while you are scanning. You should look for the head region and also scan the other part of the pancreas as well. Mention on the report the size of the cyst, the structure and echo texture of the cyst, and especially which part of the pancreas is being occupied. So in the following slides, we are just gonna examine all these serous cystic neoplasms. This transverse image shows classic serous cystic neoplasms of the pancreas, and this finding is classical findings. You can see multiple tiny cysts resulting in an echogenic and nearly solid appearance. This is not the solid tumor, but actually because of its appearance it looks like solid. These are actually tiny cysts which give rise to appearance of solid tumor. That's why it was previously known as microcystic adenoma due to multiple cystic appearance. A large cyst component is also seen at the periphery of the lesion. There is no pancreatic duct dilatation, which is very important to note. This is serous cystic neoplasm of the pancreas. It is typically a benign tumor. Only a few malignant cases reported so far. This ultrasound slide also shows classic serous cystic neoplasm findings, including many tiny cysts. On the image, no normal pancreas is shown. This area suggests head of pancreas. This region is head of the pancreas, while part of the liver is visible. Portal vein you can also see on the image. So this is a classic example of the serous cystic neoplasm, which at occasion you can confuse with the tumor. This is not the solid tumor. This is actually the presentations of the multiple cystic lesion, which gives rise to appearance of the solid tumor. So this is serous cystic neoplasm of the pancreas. On this ultrasound image, if you carefully look, so you can see through the spleen. SPL is mentioned as a spleen on the top, and left kidney, LK is left kidney. A tumor is visible there. These are multiple cysts, large cyst, and calcification can be seen in there. This is another presentation of serous cystic neoplasm. It shows calcification. Calcification in serous cystic neoplasm can be seen in 30 to 50% cases, and usually it will appear as an popcorn calcification. If you carefully analyze the tumor, you will find the calcification in it. This is the CT scan of the same patient, and here on this CT scan you can see clearly a hypodense lesion with centrally popcorn calcification. Spleen is visible on the right side, on the superior part. Left side, left kidney is visible. Hypodense lesion, actually this is because of the cystic appearance, and popcorn calcification in the center of the lesion can be seen. Calcification is 30 to 50%, which I mentioned, is common in serous cystic neoplasm. Here on this CT image you can easily appreciate this calcification. CT scan is actually very important to pick the calcification, so therefore if there is serous cystic neoplasm, you must advise the CT scan for the calcification presence. Intraductal papillary mucinous neoplasm is shortly called as IPMN. IPMN were given some other name as well, like intraductal mucin hypersecreting neoplasm. IPMN is usually seen in older population, and as it causes dilatation of the pancreatic duct, but particularly in the head region. It may be benign, it may be malignant, as it is secreting mucin or hypersecreting mucin, so that's why it causes diffuse or fusiform dilatation of the pancreatic duct. Both benign and malignant IPMN causes pancreatic ductal dilatation. This duct would be dilated, and you will be able to appreciate on the ultrasonography. Sometime there will be only main pancreatic duct involved, sometime there will be a branch duct involved, and in some cases you will see both ductal dilatation. The dilatation pattern would be either in diffuse form or lobulated form. In the following images, let's start watching all these images. You will how it will appear if the pancreatic main duct is involved, how it will look if only the branch duct is involved, and how it will look when both ducts are dilated. So let's start watching these images. This transverse imaging shows massively dilated main pancreatic duct. You can see this white arrow is indicating massively enlarged pancreatic duct. This is because of papillary tumor filled with mucin and characteristic of main duct intraductal papillary mucinous neoplasm. White arrow shows dilated pancreatic duct. It is markedly dilated, and you can see intraluminal contents in it as well. This is actually intraductal neoplasm with papillary characteristics which is filled with mucin. It is also called as mucin hypersecreting neoplasm or dactytic mucinous neoplasm. These are both names given to this neoplasm as well. Unlike mucinous cystic neoplasm where the duct is not dilated, I have shown you previous images. In the previous images it was cystic neoplasm, serous cystic neoplasm, and there was no dilatation of the pancreatic duct. But in this case it is distinguishable feature between the intraductal papillary mucinous neoplasm and serous cystic neoplasm. In intraductal neoplasm there will be dilatation of the pancreatic duct, while in serous cystic neoplasm there will be no dilatation of the pancreatic duct. This is another patient slide, and this slide also shows intraductal papillary mucinous neoplasm, which is causing massive bile duct obstruction. Here dilated duct is seen. Mind you that both in benign and malignant cases, in both IPM and S can cause bile duct obstruction. There will be definite bile duct obstruction. If bile duct is not dilated and cystic lesion is there, so that would be serous cystic neoplasm. This slide shows another pattern, and it shows side branch intraductal papillary mucinous neoplasm. It's a transverse image of pancreatic head and neck region, and it shows two cystic lesions. Arrow are indicating both cystic lesion. These are corresponding the side branch IPMN. Here this is clearly visible. The two cystic lesions can be easily seen. While so far the pancreas is concerned, you can see aorta. It is labeled as aorta, and also a superior mesenteric vein is visible. Two cystic lesions are there, so these both are suggestive of side branch intraductal papillary mucinous neoplasms. This is the slide of another patient. In transverse image it depicts a smaller side branch IPMN. This arrow is indicating small branch, side branch, and this is seen in pancreatic head. So you can clearly see pancreatic head is visible and smaller side branch is dilated. That is because of intraductal papillary mucinous neoplasm, and this can appear in this position in this way as well. So let's come and see another pattern of the IPMN, and this IPMN with main and branch duct involvement. This transverse image shows lobulated dilatation of the branch ducts and diffuse dilatation of the main pancreatic duct. You have seen in previous images main duct dilatation separately due to IPMN. You have also seen side branch dilatation separately due to IPMN. This slide shows the combination of both IPMN of main and branch duct dilatation together. This image shows enlarged head of pancreas, and proximal body of the pancreas is also enlarged. Dilated branch duct can be seen in this image. So IPMN can involve branch duct and main duct. It can be separately involved, or you can see both duct dilatations together at the same time. Mucinous cystic neoplasm is easy to differentiate from the IPMN because of its location. IPMN, intraductal papillary mucinous neoplasm, is usually seen in the head region, but so far mucinous cystic neoplasm is concerned, it involves the tail and the body part of the pancreas. Sometimes it will confuse with pseudopancreatic cyst because of its appearance. You can see low level internal echoes within this cyst. There may be multiple loculation, multiple thick septations. So these are the classic presentations of the mucinous cystic neoplasm. This is usually seen in post perimenopausal ladies in the women, and it has usually this cyst is benign, but you will see low malignant potential in this case as well. This image is mucinous cystic neoplasm with solid components. This transverse image with patient in right anterior oblique position shows lesion with relatively few lobules but considerably solid components. It is the body of pancreas. Unlike IPMN, which involve the head region, mucinous neoplasm arises from the body of the pancreas. It's a complex cystic lesion, and it seems it has thick wall. In actually, these are circumferential soft tissue components which give rise to a complex cystic presentation. Left kidney and spleen can be seen on the image. Cyst is considerably large in size. This is another presentation of mucinous cystic neoplasm. Transverse ultrasound image shows that this complex lesion has soft tissue components appearing internal echoes. You can appreciate internal echoes within this cyst. Virtually no normal pancreas is shown. Normally you can't see the pancreas at all. It looks as if it is a solid tumor with central cystic degenerative changes. At first you will diagnose it as a solid tumor with cystic degenerative changes, but actually it's mucinous cystic neoplasm and has considerable soft tissue components within it, and this is mucinous cystic neoplasm. To make it more understandable, another pattern of mucinous cystic neoplasm is included. On this image, classic mucinous cystic neoplasm can be seen. It's a transverse image and it shows cyst filled with debris and with multiple individual lobules separated by thin septation. Thin septation is clearly visible, low level internal echoes clearly visible, debris clearly visible. You can appreciate a few peripheral calcification as well. So this is the classic example of mucinous cystic neoplasm with septations. Solid pseudo-papillary neoplasm. This is the recent name given by the WHO to this tumor. Previously it was called as solid and cystic neoplasm, solid and cystic papillary epithelial neoplasm. So these were the previous name, but recently WHO has given the name of solid pseudo-papillary neoplasm. This neoplasm is usually seen in young female, and 15% happens to be malignant, and the malignant chances increases as the age of the patient gets increased. This is the example of large solid pseudo-papillary tumor. This transverse image shows a large lesion in the pancreatic tail. The tail is the most common location for these tumors. It never happens in the head region, in the body region, but it usually occupies the tail part. It's round and it encapsulated mass. You can see it's a round one, and it shows central cystic degenerative changes. You can also appreciate soft tissue components within it. Multiple name has been given to these tumors, including solid and cystic tumor. That is because of its ultrasound appearance. You can appreciate both components, solid components also and cystic components also. Another name, solid and papillary epithelial neoplasm, was also given to it. Papillary cystic neoplasm name was also given to it. So multiple name has been given, but on the report you can see encapsulated mass with central cystic degenerative changes and soft tissue component, and usually it appears in the pancreatic tail region. There are some rare cystic pancreatic tumors as well, that include acinar cell cystadenocarcinoma, cystic choriocarcinoma, cystic lymphangioma, cystic teratoma, cystic pancreatic endocrine tumor, and metastasis. Mind you that these are related to histological changes under the microscope. This can be categorized, and their particular origin can be categorized on the basis of the microscopic examination. As far the ultrasound is concerned, ultrasound cannot easily distinguishable or cannot easily distinguish between all these cystic lesions. As far as the appearances are concerned, it can be just classified as a cystic neoplasm, but certain ultrasonic characteristic give rise to differentiate between the mucinous neoplasm and the cystic neoplasm and serous neoplasm and intraductal neoplasm, which you can appreciate on the ultrasonography ultrasonography confidently, but these are the rare tumors which can be classified on the basis of histopathology. As you know that pancreas has two activity, exocrine activity and endocrine activity. This chart shows pancreatic endocrine tumors, which are generally called as PETs. PETs are two types, hyperfunctioning and non-hyperfunctioning. Hyperfunctioning PETs include insulinoma, which are common up to 90 to 100%. So most often you come across with pancreatic endocrine tumors having insulinoma setting in there. And the second is gastrinoma, which is also hyperfunctioning, and it accounts for 40 to 60% of the tumors. Other tumors include lipoma 90%, glycogonoma is 100%, and somatostatin 50 to 60%, and carcinoid PETs are 100%, which can be seen in the intestinal region. So far the 9 non-hyperfunctioning tumors are concerned. Rest of the tumors are considered to be non-hyperfunctioning. The one major reason and identification on the ultrasound imaging are their size. If size is greater than 5 centimeter, this would be definitely non-hyperfunctioning PETs. And if size range is less than 5 centimeter, maybe 2 to 3 centimeter or 1 to 2 centimeter, this would be hyperfunctioning tumors. And usually insulinoma is one of the largest tumor, one of the tumor which is very common, and its size ranging from 2 to 3 centimeter. So these are pancreatic endocrine tumors, PETs, and differentiating of these tumors on the ultrasound imaging is not quite easy. But so far the other imagings are concerned, or other investigations are concerned, it helps to identifying the exact tumor in the pancreatic region. So this chart depicts the pancreatic endocrine tumors and their presentation on the ultrasound imaging with their size and especially location in the pancreas, type of the tumor. It's all in here, and this is a very helpful chart. Before going to start the pancreatic tumors, you should have to have a look to this chart, and it will definitely help you identifying the tumors. This is the ultrasound image, and this is the case of insulinoma. You can appreciate a well-defined cystic lesion within the pancreas, and its size is up to 10 millimeter. Because it never gets bigger than more than 5 centimeter, it will be in the range of 2 to 3 centimeter. This cyst is 10 millimeter, and this is typical insulinoma. And this image is supported by blood insulin level. Blood insulin level was very high, and on the ultrasound finding, this small cyst was diagnosed. So this was insulinoma. This ultrasound image shows a small hypoequic cystic lesion. On the image it looks hypoequic, but actually it is cystic lesion indicated by the arrow. Pancreas is visualized there, left kidney is visualized, spleen can be seen, pancreatic tail is visualized. So this small cyst is in the body region, and this is non-hyperfunctioning endocrine tumor. Non-hyperfunctioning endocrine tumor happens to be more than 5 centimeter, but this is a rare case. This is another ultrasound image. This cyst is slightly hypoequic. Actually it is not the solid tumor, it is a small cystic lesion, and again it is indicated by white arrows on both sides. Inferior to this cystic lesion there is markedly dilated pancreatic duct. So dilated pancreatic duct is clearly visible. This is actually cystic tumor of the pancreas involving body of the pancreas, compressing the pancreatic duct, and pancreatic duct you can see clearly dilated on this image. So therefore, whenever you come across any cystic lesion, must pay attention to pancreatic duct, whether it is enlarged or not enlarged. In both cases you have to mention on your report for the diagnostic purpose. There are some other rare and unusual pancreatic neoplasm, including sarcomas, connective tissues tumor, including pancreaticoblastoma and lipoma as well. These are very rare, very uncommon. So I'm not gonna discuss about that, but I have discussed in the following slides some of the cases like pancreatic lipoma, because on the ultrasound pancreatic lipoma appear as a cystic lesion. If you see pancreatic lipoma, so you will confuse with the cystic lesion. Lipoma appears anywhere in the body as an echogenic lesion if it is small in size, and if it is large, so it will appear hypoechoic, but specifically within the pancreatic lesion it will look like a cystic lesion. So in the following slides you will be able to appreciate how pancreatic lipoma appears on the slide, and it will confuse with the cystic lesion as well. But this is a rare entity, and sometime you may be able, or sometime you will come across with pancreatic lipoma as well. So let's start watching these images to appreciate pancreatic lipoma. On this slide you can appreciate one of the lesion which appears hypoechoic. This is actually not the cyst, this is lipoma. Lipoma is a very rare tumor of the pancreas, but still in few cases you will come across. This is well defined and this is setting in the body of the pancreas and it is clearly visible. Do not confuse with the cystic or any other lesion, but you have to confirm it on other modalities, because on the ultrasound imaging it will look hypoechoic and sometimes it will look cystic. It is the CT scan of the same patient, the patient we have seen earlier. On the ultrasound imaging within the pancreas, there was a hypoechoic lesion which was considered to be either cyst or lipoma. Lipoma happens to be a very rare case within the pancreas. This CT scan shows clearly pancreas is visible, pancreas tail is visible. This small lipoma which is appearing hypodense within the body of the pancreas. So this scan was to confirm the appearance of the lesion on the ultrasound. So this CT is confirming the lesion. Pancreatic metastatic deposits. Pancreatic metastatic deposits are very rare and it is usually seen in only terminal state. And in this case, when you see pancreatic metastatic deposit, you will certainly see metastatic deposits elsewhere, like the liver would be involved, the spleen would be involved, the kidneys would be involved. So the pancreas would be the last area where the metastatic deposit will be seen on the ultrasonography. In the following slide, you will be able to appreciate few metastatic deposit. One is from the renal cell carcinoma. This is hypervascular metastatic deposit. The another is hypoechoic metastatic deposit. So these two are the metastatic slides which you will appreciate, and I'm sure it will give you some understanding regarding the metastatic deposit within the pancreas. So let's start watching these slides. Metastatic deposit to pancreas are very rare, and if it happens, it means that the patient is at terminal stage. There will be metastatic deposits elsewhere in the body as well, will be fully occupying the liver or spleen or any other organ of the body at the end, and at last stage it will appear it will involve the pancreas. Here this is a mets from the breast cancer, and you can see a small cystic lesion within the pancreas which is actually metastatic deposit. This is another example of the metastatic deposit. Here you can see hypervascular lesion within the pancreas. So again I would say that metastatic deposit within the pancreas is very rare, and if it happens, it means that the patient condition is very terminal, and that happens in the late stage when there is no need for any further treatment, or you cannot give them any management or any medicinal or any other conservative protocol for that. Yes friend, this was all about pancreatic cystic neoplasm, pancreatic cystic lesion. Just for the understanding and for the revision purpose, I would like to conclude it and one more time. That is like you should not get confused between that, because it has so many version which I have discussed with you. But I would try to simplify it for you. Like, if the patient is suffering from acute or chronic pancreatitis and you come across any cystic lesion, it would definitely be pseudopancreatic cyst. This is the one entity. The second entity is simple pancreatic cyst. Simple pancreatic cysts are very rare. If you see simple pancreatic cyst, must look for adult polycystic kidney disease, must look for von Hippel-Lindau disease, and must look for multiple fibrosis. So these were the two entities which are the separate one. Now the third is, these are called as cystic neoplasm. Cystic neoplasm are three types. Number one is serous cystic neoplasm. Serous cystic neoplasm happens to be very common, but these are non-malignant, these are benign cysts, and it will give rise to the appearance of solid lesion because of its presentation. When these small confluent cysts combines, its walls, it's the wall where they are unite with each other, it give rise to increased echogenic pattern on the ultrasound. So you will confuse with a solid mass, but in actually this would not be solid mass, this would be actually multiple cysts. So these are called as serous cystic neoplasm. And another distinguishing feature is it will involve only the head region. When this lesion is in the head region, this would definitely be serous cystic neoplasm. The another two are called as mucinous neoplasm. Mucinous neoplasm is actually involving the body and the tail part. It would never be in the head of the pancreas. It will involve only body and the tail part. In the serous cystic neoplasm and the mucinic cystic neoplasm, there will be no ductal dilatation. So this will differentiate these both tumors from the intraductal papillary neoplasm, IPMN. So IPMN has a ductal dilatation, while serous cystic neoplasm and mucinous cystic neoplasm, these two are having no ductal dilatation. So therefore, pay attention to the ductal dilatation. If ducts are dilated, whether a main pancreatic duct or a branch duct, if any one of them is dilated or both of them are dilated, it would be definitely intraductal papillary neoplasm, or in short you can call as IPMN. While in serous and cystic mucinous neoplasm, there will be no ductal dilatation. So these were five entities which I have tried to discuss on the images. So again, either it would be a pseudo pancreatic cyst, or it would be a simple pancreatic cyst, or it would be a cystic neoplasm. So cystic neoplasm are consist of serous cystic neoplasm, mucinous cystic neoplasm, or intraductal. Intraductal, as the name show, it will definitely involve ductal region, or in short you will call it IPMN. Hopefully this lecture, this demonstration will help you to understand all the cystic neoplasm of the pancreas, and you will be able to write the effective report for that. And beside this, you will be able to advise the further workup. If in case of any doubt, always advise the CT scan, so for the further workup. I do hope that this lecture, this demonstration will be helpful for your knowledge and for your further knowledge enhancement. Keep watching my videos, keep giving me your feedback. So we'll see you in the next video. Till then, take great care of yourself. Bye bye.